Well, welcome. My name is Tom Gaziano, and I'm a cardiologist from the Brigham and Women's Hospital, and I'm at Harvard Medical School, and I am chair of the Science Committee for the World Heart Federation. We welcome you to the Heart Café, Taking Your Medicine, the challenge of adherence and the promise of fixed-dose combination therapy. I'm joined by three distinguished colleagues, Professor Elijah Ogola from the University of Nairobi and president of the Pan-African Society of Cardiology. And Dr. Sarah Krause, a senior clinical researcher at the University of Cape Town, and Professor Fernanda Lanas from Chile. We welcome you to discuss adherence and particularly the potentials that we may have and promise of fixed-dose combination, also sometimes known as the poly pill. But let me set the stage for a couple minutes. For those of you who were able to attend the opening ceremony this morning, we heard Dr. Ed Fry talk about Dickens's comments about the best of times and the worst of times. And so we have a situation where 18 million people die of cardiovascular disease a year. That may be the worst of times. The best of times, over the last 50 to 60 years, we've seen almost 2 to 3% reduction in cardiovascular age-adjusted mortality over time. The worst of times, in adherence, we have up to 50% of patients 6 months after a myocardial infarction are no longer taking statins or have their blood pressure controlled. Less than 10% of the world's population, which is nearly 1 billion people with hypertension, have it controlled below the threshold of 140/90. Less than a third of patients who are at risk for cardiovascular disease and primary prevention are adherent to their medicines for a lifelong condition of diseases. So those are challenges again. Best of times. In 2003, there was a celebrated article in the British Medical Journal about the opportunity for the poly pill. And if many of you have seen the cover, it's this large white pill, like either Stonehenge or Mecca or something, people marching towards it as that this was the solution for them. A lot of promise at that time. They promised 5 or 6 medications could reduce cardiovascular disease by 80%. That was 2003. Nobody ingested a poly pill of that type for another 10 years in terms of clinical trials. But in those clinical trials, in HOPE-3, TIPS-3, poly-IRAN, we saw anywhere up to a 25% reduction in primary prevention for myocardial infarction and mortality among people taking a combination of aspirin, a couple of blood pressure medicines, usually an ACE inhibitor or a calcium channel blocker, or a statin. In secondary prevention, we had the SECURE trial that was released in this most recent ESC this past 2022, which showed again up to about a 25% reduction in mortality and cardiovascular events for people taking this poly pill compared to usual care. So we have again best of times, worst of times, where we have medicines that are available to some people in some parts of the country to reduce cardiovascular disease, but we don't have a lot of people taking them. Those are problems that may be related to patient challenges. Think of yourself as a patient trying to get a prescription filled at the pharmacy. Think about having to come back there every month. Think about the challenges of cost for many people in even high-income as well as low-income countries in getting access to those medications. It's a challenge to be taking a pill every day for the rest of your life at the chronic condition, so whether you're starting at 30, 40, or 50. Provider challenges. Thinking about trying to see your patient every month to write or renew that prescription, to remember what the guidelines are for managing blood pressure and cholesterol or heart failure, and the challenges that we have for getting people to take this. Think of the healthcare system challenges in terms of providing medications. I've spent time working in different sites in South Africa and Argentina where there are stockouts where the medicines have been prescribed by the physician or the nurse or whoever has the prescribing authority, and the medicines aren't available in the clinic pharmacy. So there are many challenges for us. And so what we want to do is take some time today, discuss with our panelists what are some of those challenges and how might fixed-dose combination, in addition to other solutions, help achieve heart health for our patients all over the world. So let's start with you, Elijah. You've had much experience both in your home country of Kenya and throughout Africa. Can you tell us specifically what are some of the health systems and healthcare provider challenges and solutions that you've seen work in your country and in sub-Saharan Africa.
Thank you very much, Tom, and thanks to the organizers for having me. As you rightly said in your introductory remarks, adherence is really a multi-component issue. And there are patient-specific issues, there are health system issues, and obviously the intervention, the drug in this case. So in our circumstances, then the healthcare system issues are particularly prominent, and you've highlighted some of it. Everything from crowded healthcare institutions. It literally takes a whole day to go to a clinic and get seen and get your prescription in an environment where most people work on a day-to-day basis in informal jobs or farms and all that. That is a real major challenge. There's the question of stockouts, as have you mentioned. So very often, despite the fact that the majority of our people get medications from the public health system, there are stockouts in the public health system, so they have to go and buy the drugs. There's the issue of short-term prescriptions. So the experience I've just described of taking a whole day to go to the hospital, and you have to do this every 2 weeks or every 1 month or so. So these are sort of the systemic challenges that drive non-adherence even before we go on to the convenience of taking the pills themselves, which is where a fixed dose combination comes in.
So you've had some experience in making changes for combination therapy. Can you tell us about some of those experiences and what you've tried and what's worked and what hasn't worked?
Yeah, the main challenge with fixed dose combinations or single pill combinations in our environment is one that until very recently they have not been in the public health formulary. And that meant that people who access healthcare from the public health system, which is the majority, were not able to get them. The second challenge is that up to now they tend to be more costly than the individual components. So that becomes an economic challenge. And I think the third challenge is the healthcare workers themselves, especially the primary healthcare workers, which of course are the guys we rely on for treatment of hypertension and all that. Understanding the whole concept of fixed combination and what contains. One of the issues is, of course, inherently fixed dose combinations have got proprietary names. So you find that the primary healthcare worker does not know that, for example, this combination contains, say, what? Losartan and ARB. So you find a patient who is in a combination that has got losartan and maybe has got valsartan or telmisartan and all that. So also the understanding of the primary healthcare workers as to what these contain. And maybe finally, I think it's sort of in the clinician's DNA that you won't have that clinical leeway to titrate as per your clinical competence. So this sort of pill that is made for you, there is a little bit of hesitancy there. And incidentally, we see that hesitancy more in the specialists than in the primary healthcare workers. Yeah.
Sarah, that's your cue for you as somebody who's involved in taking care of heart failure patients. Or experience. There's a complication, a challenge of many different medications for heart failure patients, as well as for primary and secondary prevention of ischemic heart disease. Share some of those experiences that you have and what you think are some of the challenges in South Africa or globally.
So I think that heart failure definitely poses a different challenge to other cardiovascular conditions because it's sort of a coalescence of so many different conditions. Can you not hear me? Can you not hear me now?
I think it's off. I think it's off.
Sorry?
I think it's off.
It's on.
Mm-hmm.
Is my hair in the way? Is that better? No? I will try and speak loud. Oh, there we go. I'll try and speak louder. So I think heart failure sets a different set of challenges because it's sort of the final common pathway of so many conditions. And each of those conditions have different challenges and respond to therapy in different ways. In terms of the challenges that patients see, I think that one of the biggest roadblocks to adherence that I've experienced or witnessed is really that clinicians underestimate the consequence of underprescribing and what the effect it has when heart failure patients don't get better from the treatment that's been given to them because they haven't been able to be seen frequently enough to actually be up titrated appropriately. And they get a sense of loss of faith in the medical profession because they're not actually improving over time. I also think that we sometimes underestimate the effect of how much diuretics impact life, and patients find that very distressing. The other thing that I've experienced is when we rush titration, patients get fear about reintroducing those medications, particularly with beta blockers in patients that have wet heart failure, so they've decompensated. And you really have to look back and address those fears in order to convince patients that it's safe or that their next experience is not going to be the same. I think that the fixed dose combination treatment idea has to be integrated into a heart failure program, possibly at a later stage in the treatment and not in the acute phase, because we do need that flexibility to treat each heart failure patient differently. If you have a hypertensive heart disease patient who's got heart failure, they have higher blood pressures, they don't have the same type of response to higher dose ACE inhibitors when you initiate them compared to dilated cardiomyopathy. So there has to be flexibility within the system, but there is a role and a space for that.
So, sir, you work in an environment not only complex at heart failure, but an environment in southern Africa of infectious disease on top of cardiovascular disease, where there's still prevalent tuberculosis and those complications in the cardiovascular system and HIV. But there's been successes in antiretrovirals and combining them. Can you give us some sense of what we might be able to learn from some of those experiences from the treatment of infectious disease and combination therapy?
Yeah, so for those of you who are not familiar, TB treatment programs adopt a DOT system, which is basically directly observed therapy. And in its truest form, this is a healthcare worker watching a patient swallow their medication on a daily basis. And in South Africa, this implementation is varied in terms of you have inpatient care for sick patients that wouldn't be able to walk to the clinic, so they get admitted to TB hospitals, and then clinic-based where patients move, and then community-based. The reasons for the implication is really that there are epidemiological implications for the TB epidemic. And if you think about that in terms of drug-resistant TB, there's not only a risk to population, but there's also a cost implication. So if you get extreme drug-resistant TB, it is 4 times more expensive than treating MDR TB, which is 103 times more expensive than treating drug-sensitive TB. And I think what we've learned through the system is that really we can learn a lot, and there's a role for this kind of approach in heart failure. Because it is a patient-centered case management system, it fosters accountability for the patients, to keep up to have frequent interactions with the medical fraternity, but not at a clinic level, at a community level. The one thing we've learned from HIV is that when we started treatment in HIV patients, they had to have a treatment buddy. They had to have someone that knew they were on therapy, and there was an accountability. So it wasn't all on them to remember. And we're dealing with sick people, they have different struggles. So there's that camaraderie that you get from having to be in a program where other people are experiencing something. I think that in heart failure, the cost implications if we look at what it would cost to implement such a program versus what we might gain from reducing hospitalizations and death and the complications of advanced heart failure, there is a place for it. And I think in the beginning, particularly in the first few months of therapy, there's this definite space that we might improve up titration to get patients to a point where they could take a poly pill.
Very good. So both Elijah and Sarah have introduced some challenges and barriers, and our next panelist, Fernando from the University of Frontera at Chile, is also a member of the Science Committee of the World Heart Federation, has been involved in many of the roadmaps, and particularly the secondary prevention roadmap, and which is a focus of the World Heart Federation to guide countries in LMIC how to overcome barriers to healthcare and treatment guidelines and initiating treatment guidelines. So Fernando, can you give us a little perspective on both secondary prevention and maybe your thoughts on primary prevention, but how fixed dose combination or any other efforts might help us in adherence to medical therapy?
Yeah, I think my can you hear me or not? No.
It's a little.
What about that?
Okay.
Okay. Well, the interest in secondary prevention, personally, and I guess from other institutions, comes from our results from the PURE cohort. If we the PURE cohort is an international cohort of about 200,000 individuals. And when we look at the people who entered the cohort, we have about 5,000 people who already had a myocardial infarction and a stroke. So we look at the lifestyle in this population and the treatment they were receiving. And it was very impressive that if you think in lifestyle, just in three things, so no smoking, have a healthy diet and exercise. Overall, in all the countries that it goes from high to low income countries, the compliance with these three lifestyles, it's just 5%. So only 1 out of 20 people after an MI or a stroke really have a healthy lifestyle. And if you look at the use of the approved medication like aspirin, statins, and ACE inhibitors or beta blockers, the overall use was very, very low in middle income countries. It's about, of the three, three or more, it's about 20%. In low income countries, almost none. And even in high income countries, it's about 50%. And it's countries like Canada or Switzerland that are probably one of the best health systems. So we think we need to try to improve this initiative of the World Heart Federation, and of course it's an initiative of many governments. And we are working the guidelines tackling three areas. That is the individual, what makes the individual more willing to adhere to treatment, and there are many things that you have mentioned already that are part of this. The physician, so the medical inertia, I think it's a major problem. And finally, the health system. And so in countries with a very similar income, the degree of success of secondary prevention and also primary prevention is quite different. And I think it depends on the infrastructure of the health system. So how you make the diagnosis, how you provide the medication, how often can you do the follow-up, and how you convince the physician to follow some rules.
And can you comment on the use of fixed dose combination in Latin America?
Yeah, I think it's. We have a position paper with the Argentinian Society of Cardiology about that. I had to look at the part of if it is cost effective, and it is. It is if you consider generic drugs, not brand drugs. And there is wide evidence of the benefit in the literature. and it's used frequently in private practice. Any combination of antihypertensive drugs or statin plus ezetimibe or now metformin plus another antidiabetic. Unfortunately, for the public health part, this combination are too expensive to be used. So, like in my hospital, we have only just one of the three options. So it's a challenge. It's a barrier. It's an economic barrier not to have fixed dose combination in primary and in secondary care too. And I am advising the hypertension program in my country, and I can assure you that they would love to have fixed combination doses in primary care for hypertensive patients. But it's just too much over what the health system can support.
Sure. So I think we've been talking about, particularly at the doctor-patient relationship and prescribing, those challenges. There are many countries where there aren't very many cardiologists, let alone primary care physicians. And often clinics are managed by nurses primarily, and in some places not even a nurse is available all the time. What are each of your thoughts within your country or your regions about expanding prescribing authority or ability for other providers, supervised by physicians if necessary, to prescribe these medications? Elijah?
Excuse me. Actually, in our country, we already, and most of Africa, we have what they go by different names: medical assistants, clinical officers, and all that, who are actually not nurses. They are people trained in diagnosis and treatment, and not at degree level, and they have the license to prescribe, and they have been really fundamental in expanding care to services. I mean, when I grew up, all the ENT work, all the ophthalmology work, and all that anesthesia when I was a medical officer out there in the field was all done by these clinical officers. And they have been fundamental to the success of the HIV programs. So really there's no reason why we cannot extend that experience to NCD work.
Yeah. Sarah, comments?
Absolutely. Can you hear me?
No.
Can you hear me now? Okay. I agree. Adding to what Elijah said, just thinking about the role communities have in HIV, the experience of engaging patients in mentorship, in counseling, in advocating for conditions. And I think that we don't give enough credit to our patients. A lot of my patients could give very sage advice to their partners, to other people around them. When I tried this and it didn't quite work, I took it at night. I don't take my diuretic at 8 and at 2. I take it when I get home from work at the bigger dose and a smaller dose in the morning. I think patients have the ability to do that, and it's not necessarily dictated by their education level. It's about how much we've empowered them as clinicians in terms of their partnership with us, as in being in control of their own care. And teaching patients how to weigh themselves and adjust their diuretic is the simplest form of that. But I think that there's definitely a space for engaging with patients that do have heart failure, that it can be advocates and teach other patients how to up-titrate their medication as well.
Fernando?
Yeah, I will refer to two situations. One is the situation of Chile, of course. Since I was a medical student, really the management of hypertension and diabetes was done by a team. So it's in the public system that covers about 75% of the population. And there is a physician But the nurse has a crucial importance there, and I was in charge of the programs in my region, and we visit different places, and then sometimes you are visiting a place that we're doing very well, and suddenly all the result dropped. And what's happened is that the nurse moved to another facility, and the new one hasn't taken the responsibility. So I think the importance of the team is quite important. I mean, the physician, the nurse, the physical therapist, the dietitian. And I would like to mention the experience from a group in Colombia, that what they do was to went to the houses of the individuals who are known to have hypertension, and they control the hypertension there, and with a simple algorithm that was available in a palm, they were adjusting the treatment according with the blood pressure they have. And it was not done by physicians, nurses, or even health workers. It was just general people with some training. And the results in the control of hypertension was very high. So about 70% of the individual has adequate blood pressure control. The other thing they did was they brought the medication. So the patient received the medication in their house, and the people who were doing the visit used the opportunity to educate the family, I guess, to take the blood pressure to all of them, and a good recommendation. The problem is the implementation of a program like that. It has economic problems and also legal limitations.
So you brought up a point with that. First of all, I'm going to turn to the audience. Get ready. We're going to open this up to everybody. I'm going to ask one more question to the panelists, but then I'm going to come back to you. As Dr. Pinero, the president of the World Heart Federation, said this morning in his beautiful quote of a poem from Argentina about the conspirators, we are in this together. So we have a panelist, but we actually have, I'm sure, a lot of excellence and expertise sitting among you. So be ready for questions, but I am going to come back to this question and explore it a little bit more. I think Sarah addressed it as well. This issue of, we've talked about provider or healthcare system. We just started to touch, I think, Fernando, a little bit on patient self-empowerment and what things we can do to have them be involved in their own care. And Elijah initially started this out with a patient who has to spend an entire day, and I've seen this in the clinics working in South Africa, where they get up at 5 or 6 in the morning, they walk to the clinic for an hour, they queue for 3 or 4 hours, they see the provider if they're lucky in that time, then they get in another queue to the pharmacy, and that's a full day's job. But they might have another job that they actually need to do, and so there are certainly productivity losses. So instead of worrying, and the pandemic taught us a little bit that we don't have to bring the patients to the clinic, we can bring the clinic or healthcare to the patient, and I think Fernando was sort of addressing that. So what have been your thoughts or experiences about using different technologies, home blood pressure monitoring, or local community point of care testing for cholesterol, and how these things might be implemented to help fixed dose combination therapy and having patients be cared for where they want to be cared for. Frankly, I think as much as a physician, I love to think that the patients want to come to see me. It's an inconvenience. It's taking off time from work, it's parking, or it's walking. They would rather be dealing with all their other things in their life in terms of their care. So how can we help that? And what have been your experiences in terms of ways that we can aid patients in taking care of themselves, supported by the system?
I mean, conceptually, absolutely fantastic. The reality is partly because of the digital divide in the environment that where some of us work. This has not been systematically implemented in the public healthcare sector, so that in fact you will find that it is, as of now, the patients who are able to access private healthcare are actually the patients who are able to access this sort of digitized care and taking care to the patient rather than to the hospital. So like I said, absolutely fantastic. So it's something that we really need to work on, with the policy makers and policy implementers to see how we can integrate this into the broader public healthcare system.
Sarah?
Yeah, I agree. I also think that we need to consider the responsibilities we have as communities, as employers, to bring healthcare to our patients. So work-based clinic work where they aren't taken away from their work situation for the entire day. There's a medical aid program in South Africa that allows you to pay a certain amount in addition so that your domestic worker who comes to work for you can get a few visits that are paid privately so they don't have to go access the public health service. These are just ideas about how employers and communities can get involved. I do think that the digital divide is a problem, and digital health is great in theory, but on the ground, even in a place like Cape Town, it is nearly impossible to rely on that. And I think that if we don't understand that reality, we're just going to implement things that aren't going to work because of the infrastructure that is there.
So that's their significant financial infrastructure outside of the healthcare system that we need to be alert to in terms of our advocacy for what we need within healthcare is general infrastructure in the country, education, but certainly broadband access and electricity. I know that's also a very basic problem. So
maybe just one
Sure.
comment there. While I agree with exactly what Sarah said, which is the same thing I said, but the sort of silver lining there is that, for example, Africa has got massive penetration of mobile technology.
Yeah.
So it's something that just needs a little nudge, to effect.
Agreed.
So Mahela has a microphone here, and she's looking for somebody to come and get it. Anybody? Questions from the audience? Please just introduce yourself.
I'm Dr. Khanke. I'm from India. It's a great symposium. We are all looking at various modalities. What I have observed in practice, heart failure is so heterogeneous. And in a country like India, where population is 1.3 billion, it's really, really heterogeneous. But I just want to have one passing remark. We are looking at deliverables of the healthcare, but fortunately, what has really come out with the generic medicines, especially the ARNIs, coming into focus, they being generic, the latest drugs are available at a very, very economical price. For example, this is not particularly about any country, but my country, the ARNIs which are generic are available for less than 25 cents a day therapy. So that's a huge progress we have made. So as we move forward and try to have a comprehensive outlook towards heart failure therapeutics, especially in different geographies, the idea of incorporating the latest guideline-based therapies, which becomes, I don't know what's the scene in other countries, which will be generic, should be at least brought at the forefront and given that opportunity of the best medicines given to our patients. So thank you so much.
So thank you for the question. Actually, can I ask him a question then? So ARNI is in itself a combination therapy, 2 pills at least. Has there been much of a movement in India for other fixed dose combinations?
Yes, we have a lot of combinations in India. We have a combination of metformin and also with, not metformin, metoprolol and also other CCBs. Now India, what we do is that we have CCBs which are specially derived from the Japanese research. And we have a combination of the CCBs, beta blockers, and ARBs. And we have a plethora of those products which are licensed and with evidence generated from them also. So, yes, thank you very much.
Thank you, and thank you for the panel discussion. My name is Vishal Mashra. I'm a clinical pharmacist with special interest in cardiology, and I just want to share something that we've done in England, particularly with the NHS being particularly strapped or capacity being limited, is that we've brought our cardiologists out into our community. We've been working on this for the last 2 years in the modality that I work in with about 80,000 patients. And what we've been able to do is upskill non-physician staff, so those physicians associates, the nurses, the pharmacists, and anybody that really would like to get involved in doing some prescribing in groups of patients. And we're upskilling those and seeing the benefits now. So it's not cardiologist or GP led, it's more other healthcare professionals. So I think, you know, some of the stuff that you guys have shared is happening in pockets around the world, probably in different ways. And I just thought it was important to share that this is happening in England as well.
Thank you. You remind us of another member of the healthcare system that we didn't talk about much, is the pharmacist, and a very key role. And we're involved in some work in Boston using a pharmacy-led program with navigators or health coaches who are doing on a protocol written by the cardiologist in our hospital, that they have complete prescribing authority to manage patients through the entire titration of blood pressure and cholesterol. So I'm going to turn to my colleagues and ask them what is the experience of working with pharmacy in their countries, and do they see any challenges with that process, or what are the opportunities?
We had the experience in some of our sites where the pharmacist was involved, and the way they organize the work is that they refer to the pharmacist the cases that has presumably resistant hypertension, and it was very successful because he has 2 or 3 long sessions with the patient and the family to assess first how they are following the treatment, then advising them how to improve the treatment. And this experience has expanded to many places in the country. So I think it's quite important in several areas, but specifically in the advising of the people who does not reach the goals, it's quite important.
Well, yeah, well, I think that it comes back to what you were talking about before about the team.
Yeah.
And if you have pharmacists that are supported when they don't feel comfortable or they feel that there's an issue, they're a perfect place, because patients don't see doctors every month, but they see the pharmacist every month when they go and get a refill. And a pharmacist being able to say, well, actually, I think we should come down on your diuretic, or, you know, maybe why aren't you on an optimal dose of an ACE inhibitor or an ARNI? You know, there's this room for that. I think that we would have to, I think our pharmacists where I work are very overstretched. So it's all about capacity building at different levels, because you can't do that in isolation. It has to be a team effort.
This happened really in the reality of the public health system, where in the health unit has a pharmacist, and most of them have. It doesn't happen in private practice, of course, but in Chile it's about 3 out of 4 are benefits of the public system, so it reaches a big group.
Elijah?
Yeah, well, it's something that we've not utilized very much, partly because of the reasons that Sarah said, that professional pharmacists are actually quite few in our environment, and many of them get immediately poached into industry. So many of the people whom the patient interacts with in terms of filling the prescriptions are actually not pharmacists. But thinking about it, this is another opportunity for task shifting, because we have a cadre, at least in my country, of what we call pharmacy technicians or pharmaceutical technicians. And that is a category that we can use to enhance this.
So any other questions from the audience? We're all in this together. All right, well, I'm going to ask a different question, and raise your hand if you do, and we'll move the discussion back to you. But we've talked about some of the other system things that might be important. What is the challenge, or what are solutions to some of the challenges of procurement? So sometimes we have stockouts of medications. Is there anything about fixed dose combinations that you see, or do we need to change with regards to the distribution systems in countries to make sure that we have adequate supply of medications for those that are in need of them? Fernando, would you have to?
Well, I would love to have that. We have been in some discussions with PAHO. PAHO is pushing strongly for the development of the heart initiative in Latin America, and it has been very successful. And one of the things that the heart initiative has is the use of starting the treatment of hypertension with two types of medication, not in everyone, but in most of the cases. So it's the ideal scenario for having a pill who has two combinations together, and you can split it. So you can start with AF and then go to the continuous. And Pedro Ordóñez was exploring the possibility of having, through PAHO, bulk buying of medication for different countries. But as far as I know, still hasn't been successful.
Yeah. So something like the PEPFAR for the HIV drugs, making sure that we have a real supply and support for global distribution of medications. It seems like what do we think we can do with regards to international call, or what would you say is necessary as part of universal health systems for us to increase the supply of medications to our patients? Any thoughts, Elijah?
Yeah, well, obviously the whole supply system is very crucial. I don't think that is something that we're going to sort out simply by fixed dose combinations. I think our colleague from India, alluded to the fact of generics. The problem with generics in an unregulated system is you don't know which is chalk and which is medicine and all that. So the capacity to regulate. I think the whole issue of local manufacturing capacity is extremely important. I mean, the global supply chain issues that COVID brought to the fore, enlightened us about that. So local manufacturing capacity, quality generics, in addition to simply addressing the inefficiencies and corruption issues within the bureaucracies that we work in.
Any successes in Africa that you can say that have addressed some of these issues?
Maybe Sarah's got some success stories.
Well, I think the one encouraging thing about the HIV epidemic is showing that it's possible. And how throughout my career, the transition from not having access to antiretrovirals, having access to medication that had huge amounts of side effects, to having fixed dose combination treatment, and that process, it is possible. The supply chain issues, I think really one of our major fundamental things is cost. It's easier for me to refer a patient for heart transplant than get an ARNI in South Africa in state. And I only have one transplant service. So, and that's related to cost. So I think that there are so many amazing new therapies that are coming out that are available, but they're just not available to a huge population. And maybe there does need to be some kind of accountability in our work with industry to say that, yes, when you can pay for that, and we understand that you need that, but there needs to be sort of a humanitarian aspect to developing these drugs, because otherwise, there's many, many years where patients don't get to the generic phase. So maybe we need to address that as well.
Sure. Thank you. Other question?
Hello. You mentioned already a little bit about this, but can you hear me there? Is that better? You mentioned, I think, some of these issues, but you mentioned PEPFAR, and Sarah was mentioning HIV. And one question I have, we've been talking about the poly pill for more than 20 years for cardiovascular disease, while for infectious diseases, fixed dose combinations are being used, are being implemented. There are a lot of things on task shifting as well that have been successful, and as you said, is an example of success. difference between the success in infectious disease for things like fixed dose combination, task shifting, and we cannot do the same for cardiovascular disease. And maybe for people in Africa in particular, I would like to hear your why is this divide?
I think the answer is both simple and complicated. It's a question of resources, as Sarah has just said, because the whole thing underpinning the success of the infectious disease programs, PEPFAR, the TB programs, the malaria programs, is that they are funded by the international community. So any patient with HIV or TB anywhere in Africa, supply chain issues notwithstanding, is guaranteed to receive the drug that they need at no cost to them as an individual. And that really is the big difference, because the perception of NCDs as a healthcare need in the developing world has not actually been appreciated. So that really is the issue, is actually resources, that the international community have committed resources to infectious disease programs, which have not been done for non-communicable disease programs.
Sarah, how can we make that happen?
Well, I think it also goes back to this heterogeneity of heart failure that is this big challenge, because not every heart failure patient is the same, because there are multiple causes. And I think the recognition of that is quite important. I do think that the polypill we could get to that point. I think the way we get there is quite different. And I think that we can learn from the DOT system and the HIV system in terms of the other difference is the interaction that people have with the community and with the healthcare facilities, and they built those in. They built in counseling, they built in treatment buddies, they built in the DOT system. And I don't think we've done that with cardiovascular disease. And that's maybe a place to start.
So I'm going to move on to another sort of myth or challenge to fixed dose combination. And that is this idea, and maybe it's mostly from providers. I want to see what is your answer to this question, is that we're moving towards precision medicine. And that we know genetic codes of patients and responses to medications and imaging that can tell us everything about an individual patient in front of me, and I want to tailor that therapy to that particular person. You brought that up a little bit in the beginning, Sarah, in terms of the need to tailor, titrate. Not everybody ultimately, and many people ultimately will end up on the same 3 or 4 drugs and similar sets of doses, but how do we convince the world that, whereas we're moving toward precision medicine in one way, that we are trying to simplify a set of medications for people in another direction? How, is that a contradiction? Is that a problem? What's your thoughts?
Yeah, I think it's a problem. It's my personal experience with the polypill. The one we are available only has 20 milligrams of atorvastatin, and we are in the Cardiology Society insist in using high doses of potent statins in patients in secondary prevention. So as you say, probably 20 milligrams may be appropriate for a proportion of individuals, but most of them will need a higher dose. So I don't think it would be too difficult to have different alternatives, because in other fixed dose combination like you have in hypertension, you have a range of doses and a variety of medications, so it's much easier to select the appropriate one, and it's hard to believe that with one fixed dose you will handle the blood pressure and the cholesterol level of everyone in secondary prevention.
Questions? Sure.
I just want to make a passing remark. The whole idea about progression of a patient on heart failure, how we really monitor it, that also is work in progress. Because, it's not really well defined. I don't know the latest practices in other countries, but in my country it is not really well defined how you look at the progress of a patient. How do we really bring about dose titrations? really suitably make it the best therapy for him. Because even if you look at the evidence on the biomarkers, that is also not really concretely coming out that biomarker directed therapy is one of the best ways to do it. So like, it's actually a lot of work and evidence which needs to be generated, incorporated from different geographies, different populations, and then maybe work up on some standardizations, and then that could be the way forward.
Yeah, it's very good. We now have AI that can write medical articles for us. So I think we're going to be able to figure out ways to create those algorithms. The technology divide and implementing them, I think, are important. Do we have anybody representing a civil society group here in the audience? Anyone? No, because I want to come back to Pablo's question about why isn't there a PEPFAR for NCDs, and in addition to, for whatever reason, President Bush initiated that project, there is also a significant public and patient-oriented driven movements for HIV treatment and care. Maybe the panelists can speak to how do we engage our patients or the communities to want fixed dose combination or increased broadband and infrastructure build-up of the healthcare system. How do we engage them, and what should we be doing with that? What's been experiences going on in any of your countries?
This is where I would have wanted to listen to, for example, the civil society organizations here. They are much smarter in terms of advocacy and all that than a simple clinician like me. But we clearly need to do that, because all these successes that happened, especially with HIV, was through the activism of the patients themselves. And for whatever reason, I have no answers. We haven't been able to do that with the non-communicable disease patient community.
So you mentioned that patients are very smart and they actually figure things out. What are they doing in this area, do you think?
So I work in a pocket clinical service that treats cardiomyopathy patients. And we see a lot of dilated cardiomyopathy with heart failure. So that's really my area that I've been working in. And I've been so encouraged by how patients have done really well in our setting based on two things. One is the creation of a registry, and so that there's this consistent follow-up. And during the COVID pandemic, for example, we used the research registry to locate and advocate patients, and the follow-up system has allowed us to track down patients that were lost during that period. And the other thing is that when you explain to a patient what a medication does and you spend a little bit more time with them, their ability to understand and know what is wrong if they get the wrong prescription, to understand why they're taking something. I've been so beautifully surprised by how good patients are. I had a very uneducated patient who once said to me, Dr. Krause, if I take 5 milligrams of enalapril, I feel fine, but when I go up to 7.5, I don't feel quite so right. So I'm just going to keep taking 5 milligrams. Is that okay? And I thought, hey, that's wonderful. He knows the name of his drug. He knows the milligrams. He understands. And when he got the box of 10 milligrams, he was like, I don't know how to use this. And he had a place where he could contact and he could ask. So I do think that some of the answers to these problems are in patients. So if you said to a patient and you mapped out, we're going to give you multiple meds to try and get you to this point, and then there's going to be a polypill. If you went from multiple meds and you just gave them a polypill and you didn't explain that transition, they would go, okay, I was on so many drugs, now I'm on one. Does that mean I'm not getting the same treatment? So you have to kind of understand where the patient is coming from. So
no paternalism. We're moving away from that, I think.
No.
Yeah, exactly.
Yes.
Fernando, an experience of how to engage. Are we stuck in the ivory tower, or how can we get our hands dirty and engage patients and movements?
Yeah, well, in my country, I've seen a very successful public pressure groups to get medication that are very expensive for cancer or biologicals, and they get it. And it's done for free for the government. But I think it's much more difficult for fixed dose combination, because the argument is, well, I want to have this pill for the low price or for cheap. But but the answer is, but you have the components, and they are very free, and it's just are there for you to take it for free. So the argument is not so strong like in cancer. You don't have an alternative that is equally effective and cheaper. So I don't think that it will be very successful, and my experience that they haven't tried that. We can do a scientific argument that it is proved that it improves compliance and reduces events, but it's not very compelling to the health authority, I would say, and even to the people. They say, well, if I just take these 3 pills, I get the same effect. So I don't think we will advance more on group of patients, but I don't have the experience, to be honest.
So we're coming to the close. Are there other questions from our audience here? If not, I'm going to give each of the panelists a minute to answer. What promise do they see from fixed dose combination? When did they see that coming in their own country? And what would be the first sort of barrier they'd want to remove to make it happen?
So very briefly, at least in the hypertension world, I think the experience with fixed dose combinations has been there for some time. It has been encouraged. There are several options available. So it has led to acceptance. I think the sort of conceptual jump is to go beyond a single disease entity into prevention. And that's where the issues have been, like he said, about what dose of statin, what gets in there, do you need aspirin, do you need a beta blocker? So my thinking is that in terms of escalating it into prevention beyond just a single disease entity, maybe prioritizing secondary prevention, because then it is quite clear-cut what you need, what doses you need, and probably get that step before then we get into primary prevention.
Sarah?
Oh, I think it's important to put our heads together and with clinicians and what their challenges are, what patients' challenges are, and trying to understand a little bit more about the gaps. And because we often think of them in silos, I do think that the polypill has promise in heart failure, but if we ignore the heterogeneity of it, and the challenges of getting patients to those doses, we're going to miss that opportunity because we're never going to get there. And so we I would say we have to think in heart failure as the polypill as step 2, not step 1 in initiation. And that might be something that could be done through pharmacy. When you see that your patients are on full dose therapies, but they're on 5 tablets, isn't it time to say at that entry point, let's change to polypill?
Lendo, closing remarks.
Yeah, I think the 2 important issues is the availability, the affordability of the fixed dose medication, and second is to have some range of alternatives, not just one, at least 2 or 3, or as has been done in some initiatives. In the case of permanent, is that you can split the tables, very simple things, but can be very useful.
So instead of that Walden Law picture of the one giant pill,
Yes.
we need maybe a Stonehenge or multiple different options for us for doing this. So polypills rather than polypill, I hear, starting secondary prevention and allowing for titration and then switching to it. I think that those are all things that fit the concerns of physicians as for precision medicine. Well, I think this brings the hour to conclusion. Thank you very much for attending the Heart Cafe, and big round of applause for our panelists.